Currently, I am critical care consultant at Apollo Hospital, Mumbai, and been involved in the development of intensive care and also been involved in development of transplant services also at Apollo Hospital, and I'm specialized in ECMO services.
So,
Ventilator.
doctor, how did your like journey started?
So,
Basically, were you always interested for this particular field, or something happened and you thought of going into critical care?
So I was fascinated by the field of intensive care, the innovations that come up every 6 months, and there is a lot to do in intensive care. Emergency handling is my passion, and I used to be fascinated by ventilator support and hemodynamic support during my residency, and that made me think about pursuing this career in intensive care. It is full of enthusiasm, and we really need to have great amount of dedication, commitment, and versatility, and that's how the field of critical care has got glamorized over a period of time, and it has been recently it got popularized due to the COVID pandemic. As you all are aware, we have just gone by this COVID pandemic and get control. Everyone has now understood who intensivist is. Till now, the intensivist had no recognition. But to leave that apart, let me focus on today's topic, respiratory failure and ventilation in ICU. As we all know that majority of the emergency admissions we see are all due to respiratory failure. So patient may present with some other symptoms like dyspnea. He may be presenting with some amount of cough, or he may feel completely breathless and impending desaturation. Some patients may directly come with arrest kind of a situation where the patient has stopped breathing, and at that point of time we need to intervene with the ventilator support and to provide oxygen support. We may have to put the patient with a tube and put him on ventilator. So, but we really need to know how this breathlessness is defined, and how do we call it as respiratory failure when we call it as respiratory failure. So to define breathlessness, it is uncomfortable awareness of breathing. When patient feels that he's not able to breathe properly, or his effort is getting exhausted, and he feels dizzy or nauseating, or he may feel having altered sensorium. So that point of time we feel like patient is probably dyspneic. His respiratory rate will be very high. Some patients, the respiratory rate may be low as well. We call it as bradypnea. And if the respiratory rate is very high, we call it as tachypnea. So there are n number of causes which can cause breathlessness, right from metabolic causes to central causes which may lead to hyperventilation. It means any pathology in the central nervous system can also lead to breathlessness. Fever will increase metabolic requirements and also can lead to breathlessness. And you or everyone must have experienced anxiety or pain that can also lead to breathlessness. It can be a compensatory mechanism for these symptoms. And when the patient has breathlessness, his oxygen saturation is likely to be very low. So unless the saturation is low, patient may not be symptomatic. So as we know, the normal saturation is 94 to 100%, and if the oxygen saturation goes below 88 to 92%, patient may become symptomatic, and he may present with cyanosis. This cyanosis can be peripheral cyanosis or central cyanosis. Central cyanosis is basically because of the deficiency of the hemoglobin to carry the oxygen to the tissues, whereas the peripheral cyanosis may be due to cold peripheries. Patient may be in shock, venous congestion, or you may have applied a pulse oximeter on the finger, but the pulse oximeter is not able to catch the oxygen levels because of the artifacts, and probably there may be a nail polish on the fingers which may interfere with the pulse oximeter assessment. So acute onset of cough can be present in many other situations, like patients with the COPD. If the patient has got aspiration pneumonia or foreign body in airway, or some patients with the pleural pain, upper airway irritation, pulmonary congestion can also present with acute cough. And these patients may present with, a fever, chest pain, abdominal or thoracic surgery, or body swelling or blood loss can also be the cause of breathlessness. So basically, what is the pathophysiology behind this breathlessness or dyspnea or the respiratory failure? So we all know that lungs are the oxygen tank. If the tank is not filled properly, the balance between the oxygen support and the oxygen delivery gets compromised. We call it as ventilation perfusion ratio. So ventilation is something like the oxygen comes inside the alveoli, and then that oxygen gets distributed from alveoli to the capillaries, and it will reach the end organs or the tissues. And if there is any discrepancy between this exchange of oxygen, whether at the level of the capillaries or whether at the level of the alveoli, that will lead to mismatch between the oxygen supply and oxygen demand. If there is high demand but the oxygen supply is getting compromised because of these issues, there will be ventilation perfusion mismatch. As we know that when we have a ventilation perfusion mismatch, there will be either low oxygen levels, we call it as partial pressure of oxygen may be low, or partial pressure of carbon dioxide may be low. So in patients with a VQ mismatch, where the oxygen demand and supply is not matched well, especially in patients with this pneumonia or ARDS, where the alveoli have got destroyed, and or the alveoli are filled with the fluid or the debris or the blood or fluid, then the oxygen exchange is not happening at the capillary levels from alveoli to capillary, and that will lead to VQ mismatch. In that situation, the PO2 may get reduced and the PCO2 may start rising. Okay, there are other conditions where the oxygen is reaching the alveoli, but it is not going beyond alveoli to the capillaries. Instead, it is getting diverted somewhere, and that part, because that part of alveoli is not supported with the capillaries, and the capillaries are diverting the blood to other areas where the ventilation is adequate. So that part which is not contributing in oxygenation, we call it as dead space ventilation. In that situation, the oxygen levels will drop and carbon dioxide will go on increasing. So there are shunts where there is mixing of oxygenated and deoxygenated blood. That can also lead to low oxygen levels, and there may be low carbon dioxide levels also. So basically, to understand the VQ mismatch pathology, we need to understand what is dead space ventilation. So dead space is the part of the lung parenchyma or the airways which is not contributing into oxygenation and ventilation. So it can be either anatomical. The dead space can be in the large conducting airways. 50% of the dead space is in the pharynx. It doesn't have any contact with the capillaries. Whereas some patients may have abnormal increase in the dead space, especially due to damage to the conducting airways or damage to the lung parenchyma. As the age advances, the dead space also goes on increasing, and physiological dead space is also there, which is around 5 to 10%. But if it goes beyond 10%, that dead space becomes more significant, and these patients may be more symptomatic. So as we know, the dead space may be as high as 20 to 30%. And increase in the dead space will lead to low oxygen saturations, we call it as hypoxemia, and there will also be increase in carbon dioxide, we call it as hypercapnia. So the calculation of dead space is not that easy. We need to understand the perfusion mismatching with the help of scans, which is not easily possible to measure. So, but this dead space can contribute to increase in loss of efficient oxygenation. And where else this dead space can be? It can be at the level of alveolo-capillary interface, which is usually seen in patients with the emphysema, or there will be overall reduction in the blood supply or blood flow, especially in patients with the pulmonary embolism, when the pulmonary artery is blocked because of the thrombus, or patients with the heart failure, the blood flow is reduced. The blood flow, which is supposed to reach the oxygen tank as a lung, it is reduced. That will also lead to dead space ventilation, because the blood is not reaching the capillaries. Air is coming inside the alveoli, but there is no capillary exchange happening because there is poor blood supply through these capillaries. If the oxygen exchange is not happening through these capillaries, the oxygen delivery to the tissues will also be compromised. And when we ventilate the patient, over ventilation or over distension of the alveoli can also lead to shunting. And when this intrapulmonary shunt, is increased, or VQ ratio goes more than 1, we call it as intrapulmonary shunt. There are two types of the shunts, intrapulmonary shunts. It can be true intrapulmonary shunt, or when it may be due to venous admixture. So pathophysiology of the shunt is very necessary. We need to have a better understanding of the pathophysiology. Unless we understand or find out the shunt, where exactly is the shunt, we will not be able to delineate the problem, and we will not be able to correct hypoxemia, because no matter how much oxygen support you have, but if the shunt is not corrected, the oxygen support will be inefficient to provide efficient oxygen delivery to the tissues. So that's why we need to understand shunts. So if there is any increase in the shunt, we know that the oxygen levels will go down and the carbon dioxide will go on increasing. What is shunt fraction? Shunt fraction represents the fraction of cardiac output which is lost in intrapulmonary shunt. If there is more than 10% of the cardiac output lost in this,
sorry, doctor, to disturb you. There is some problem. People cannot see your slide. I just want to know if slides are visible to them.
You all are able to,
okay, it's visible, doctor, because there are few doctors who cannot see the slide.
Yeah, so probably they will have to go through these slides.
The network, I know, yes. Yeah. So please check your settings once. Thank you, everyone.
For sure, thank you. So if the shunt fraction, if the more than 10% of the cardiac output is lost in these intrapulmonary shunts, that is quite significant, and that can be a disastrous. So that's why we need to identify. So these shunts can be due to occlusion of the small airways, especially in asthma patients. If the alveoli are filled with the fluid, the pulmonary edema or pneumonia can lead to the shunt. If the alveolar collapse, especially in atelectasis, or if there is excessive capillary flow, patient is not embolized with pulmonary embolism. So these are the instances where we may find intrapulmonary shunt, and the patient may have respiratory failure. No matter how much oxygen we support, that is not going to get corrected. The another entity to calculate the shunt, or how much is the ineffective oxygenation, we need to know alveolar arterial gradient. So normal alveolar arterial gradient is 10 to 20 millimeters of mercury. And if by increasing 10% of FiO2, and if the gradient is not getting corrected, it means definitely there is alveolar arterial shunt. And as the age advances, I have already discussed, as the age advances, the alveolar arterial gradient increases, because the alveoli lose their ability to exchange oxygen with the capillaries, and especially with the emphysema, or the increase in the dead space can lead to increased loss of oxygen exchange. And this alveolar arterial gradient can be aggravated by patients on positive pressure ventilation.